Hello, everyone. Welcome to the J3U podcast. I am your host, John Jewett. With me is co-host Luke Miller. Today is on metformin. So we want to discuss the applications within physique competitors for metformin. I know this has been talked about quite a bit and lots of controversy and unclarity on the topic. So we want to provide some and just show kind of like the walkthrough of when might be a situation someone would use metformin or why people are even using it to begin with. And then just get into some of the little bit more detailed aspects of deploying it, issues around it, and how that might work within your total plan if this is something you're choosing to utilize.
Yeah, and I think one of the big things to kind of start out with would be just kind of maybe laying the framework of what metformin's kind of originally proposed for when we look at like glucose control with like type 2 diabetics and just some of the base literature around that. And its main role being like an oral compound that lowers blood glucose through a couple different mechanisms. We can see like lowering it via like hepatic glucose output, intestinal absorption of glucose, and a couple others as like its primary source for medical indication when we look at it within the medical community.
Yeah, so this is a first line therapy for type 2 diabetes is the metformin. It's the first line medication that is a go-to. There are several around this, of course. It just a slight familiarity with diabetes itself. It's primarily uncontrolled management of blood glucose and high insulin levels revolving around insulin resistance. And of course, this is problematic as it increased glucose glycation of lots of different blood cells, organs, tissues. You can lose a function around these. One of the leading causes of kidney disease, causes issues with cardiovascular disease. So multiple complications with having elevated blood glucose and blood insulin levels. So partially with type 2 diabetes is you have this insulin resistance forming, which over time could put further strain on the beta cells of the pancreas to produce insulin. So you might also have eventually a decrease of insulin secretion. Not always the case in type 2. In type 1 diabetes, this is more so an autoimmune issue with the beta cells not producing insulin. So it's not necessarily insulin resistance in a type 1 diabetic, but just more so they need to take exogenous insulin to replace what they're not able to produce. But in type 2, this could be coupled together. So revolving around treatments for type 2 diabetes is addressing these issues of trying to resolve insulin resistance. And metformin is one utilized because it can decrease, well, it works through a few different mechanisms, like you said, Luke. Primary one being action at the liver to decrease the hepatic output of glucose. So the liver can produce glucose through gluconeogenesis and increase blood glucose. So this insulin resistance that's occurring, cells aren't uptaking glucose, the liver starts putting out more. And that then gets coupled with further increases of insulin and tissues not responding to that insulin and just kind of the snowball effect. There's a few other drugs, though. Are you familiar with the other diabetic drugs? We got questions on them?
No, not really.
I actually had some come up. Ones that I like, you have a list of drugs and people are like, how many other drugs can I take? It's like, why did you even come up with this? I don't know. Just some of the drugs that people mentioned to me. There's a few other drugs in diabetes. One being Actos, which works in gene expression for around fatty acid metabolism, carbohydrate metabolism, and it does sensitize peripheral tissues, just like metformin does. One of the higher incidences of issues around Actos was edema, and it's contraindicated in patients with like congestive heart failure, which someone asked me about that, and just being around enhanced bodybuilding, one of the large issues that we have around is like peripheral edema, water retention, increasing blood pressure. So it's like this is already is like an X out on that one. Another one is a glipizide. I've heard someone mention it. It's an insulin secretagogue. So it increases beta cell production of insulin, which isn't really solving the problem. Like yes, it lowers blood glucose, but the root issue here, it's trying to reduce just glucose output of the pancreas and improve insulin sensitivity. Don't just add more insulin in. So that's when you might say, hey, why don't we just add in an exogenous insulin?
Like a baby.
And the like one of the other ones was like I heard someone mention using a GLP-1 agonist. Yeah. So GLP-1 also increases beta cell production of insulin. It also decreases carbohydrate absorption, can decrease appetite too. So I've seen some people using these like post show, but again, I think it's not getting down to like what is our real issue around enhanced bodybuilding. And so with enhanced bodybuilding, some of the main issues with using high amounts of androgens, growth hormone, is just, well, for instance, just growth hormone itself increases glucose output by the liver. Yeah. So think of as growth hormone as like trying to pull out all energy reserves into the bloodstream. And so you're having glucose increase from the liver. You're having fatty acids pulled from adipose tissue. So you have this rise in blood glucose, rise in free fatty acids. It can cause insulin resistance and prevent like uptake by tissues. So this is kind of like what we're faced with, alongside also just high food intakes, high body weights that are driving more inflammation. And those inflammatory factors can have some direct impact on insulin sites, insulin receptors in that pathway. So we're kind of getting hit by a few multiple fronts here. We're taking some compounds that increase blood glucose. We're also putting in ourselves in positions where we can have more insulin resistance occurring. And so something that might be deployed around that, of course, we use every intervention possible, right?
Yeah.
Cardio, diet, to help improve that, lower inflammation, improve health markers, but there's still like some prophylactic strategies that could be utilized. And still this first line treatment for diabetes is metformin.
Yep. And
so we see a lot of bodybuilders are now using metformin for this reason, to one, manage blood glucose. And it has some other benefits as well.
Yeah. And I think that when we look at like considering prophylactics in the first place, I think one of the big things is like their role in this is extending the lifespan of phases for us a lot of times, right? Yeah. And it's a long-term play, not only for this space specific that we're in, but especially like managing the long-term health considerations. And this is where we start to, when we discuss stack design, almost have it as like a linchpin within the majority of people's plans, because most people run into the same similar issues, right? We're running into a lot of these health marker deteriorations that are going to eventually drive long-term issues. We see NET, insulin sensitivity go down, and inflammation rise quite a bit. And we can see metformin really play a role in this. And I think this is where we kind of start to lay out why metformin really fits the bill for some of these issues as we run into this pretty stereotypically across the board with most people.
Yeah, because and like what's usually ending like growth phases for individuals, and I'll get into also like even contest prep scenario, but yeah, in these like growth phases, like you said, like usually we're seeing what's going to keep you from pushing up, and usually it's what someone might notice is like, man, my appetite has gone to shit. Like I'm now feel like I'm forced food down, or body composition is starting to get partitioned just more towards body fat, and for that same amount of tissue accrual, lean mass accrual. And then, you know, if you are, hopefully you are monitoring health markers, you start seeing health markers getting deranged. So maybe triglycerides, lipid panels getting off, and you're like, okay, this is all heading in a direction of being far from optimal. It's not sustainable. That's the thing about it. So you have to then take other measures. And so around these issues, like what is really occurring there? And it's, like I said, high food, high body weight, high PED usage. Usually at the higher body weights, sleep can be taking a toll. And then also we're just driving a lot of systemic stress too. And don't think like mental stress, but think just overall stress on the body with training, sleep going down, PED usage, all those things. And so we result in this fate of this high systemic inflammation, high amount of insulin resistance, and increases in oxidation stress. And so we have to do something with that. And that's why metformin fits the bill really well within the enhanced competitor, because it does, for one, helps with managing your blood glucose and insulin resistance. So it can, like you said, like put further the extend the growth phase without having those issues occur, possibly as soon. And also just for, I think more so from a longevity aspect, the acute stress could be reduced, but also the long-term stress. So we see with metformin outside of blood glucose management is you have decrease in inflammatory markers, decreases in oxidative stress. So just within that, just with a systemic aspect, our main issues in bodybuilding are what is it doing to the brain, the heart, the kidneys? And a lot of this is driven around high systemic oxidative stress, inflammation. So metformin works to decrease those. So it's very liable. You could say that metformin is renal, cardio, and brain protective. And then we'll have also potentially like anti-cancer benefits around metformin. It has lots of applications within that. But I think, before you get down too far down the longevity track there, because people just want to care more so like what's it doing to my physique as an as a competitor. And so yeah, that's kind of your main thing of why we would be deploying metformin, to lower those aspects of what high food, high androgens, high growth hormone, all those things are doing around it.
I think along those lines too, it's because the whole conversation for now has been like around all season is flipping the script in the contest prep. I think this is very applicable within that contest prep setting as well. Because of all those additional benefits outside the glucose control that we'll see with metformin, just keeping it in at like that 500 milligram mark throughout the duration of the contest prep for these measured benefits as well.
Yeah, no, I think that's a point, because in contest prep, you're like, hey, man, my blood glucose is great. Like this isn't going to be a problem. Like you're going to be very insulin sensitive in a prep. Yeah. And yes, you are. However, you're still exposing yourself to high amounts of PEDs, typically with increasing on the way into the show. So I would take metformin for all the other benefits that it presents with outside of glucose management, because your glucose should be relatively pretty managed in a contest prep. And so for all those other health benefits, to keep those more intact, keep yourself in a healthier state. And that it continues each phase you get into. So like off season to a prep, you won't have as much of like, so some guys have to have like, if you want to call it like a cleanup phase or a health restoration phase, like we should never have to really get to those points to begin with, but it shortens these phases because you've maintained health. Same with a prep into a post-show period into an off-season. That post-show period, it's very much a recovery state from all the stress you just put yourself through a prep. Now, if we had a tool to utilize to try to mitigate some of that stress that you are accumulating, that post-show period is just going to be much more effective and get you transitioning back into a very productive off-season phase a little bit faster rate. So I think it's kind of phase potentiating in that sense, and that you can be improved on every other phase by doing so. So it's something that could be utilized year round, right?
Yeah, and I think as we kind of walk through this, we do get a lot of questions around like, what are the issues, right? Because every drug has got to have some sort of issue. No drug comes without some sort of side effect that we may need to watch out for. And we have like a couple that we can go down. But the first one is like the question about like the influence on hypertrophy, right? Like, does metformin have a negative influence on hypertrophy via like AMPK and all this other stuff? And I think this is something that is really overstated and not fully understand, because we can like look at like isoforms of APK and like where metformin is going to have an influence and see that it's not going to be influential on hypertrophy. And I think we have data. You said the master study, right?
Yeah. So that's the one of the studies that has been usually cited for saying, hey, don't take metformin, it's going to inhibit your muscle gains. And like you said, like, and since we didn't even mention it, like the main thing about metformin and how it works at the liver to reduce glucose output is through activation of AMPK,
Yeah.
which is basically the same thing that's activated during exercise, actually. And so it causes like a decrease in the signaling that almost is like exercise would be. So it's like there's energy availability, so you don't need to now put out glucose to provide that energy. But AMPK has a few different subunits on it, several. And so metformin activates certain subunits, and the ones that it does activate is shown ones that aren't related around activation of mTOR in skeletal muscle. And so we also have to think like not just as a whole, but where is the really target sites that metformin is enacting? And one of the main sites is the liver. However, it will have some influence on skeletal muscle. And so we bring up the master study, which was a 12-week resistance training study in subjects over 65 years of age. And they were taking 2,000 milligrams of metformin a day and looking at skeletal muscle outcomes. And within that study, there was some inhibition of hypertrophy adaptations. And so that was immediate, like, oh shit, don't take metformin. It's going to inhibit your gains. And within this study, and you kind of have, it's much more in depth. So for one, you have to look at, does the subjects apply to within our population? And I would say if you're over 65, natural, and taking 2,000 milligrams of metformin a day, then this study would probably apply to you. If you're a young 20 to 40-year-old, taking super physiological amounts of PEDs, androgens, and growth hormone, and for something that's more like along the lines of maybe 500 milligrams of metformin, it's just not even a comparison. And now, do we have that comparison? We don't. So that's the thing about it. We kind of just have this one study. There was a follow-up done to kind of investigating the mechanisms a little bit more. And I would say those mechanisms seem to revolve more around this, this aging dependent process. So it's not, doesn't seem like it would be as influential in young subjects.
Gotcha.
Now, for naturals, should you be taking metformin? I wouldn't. I don't think that makes a lot of sense because around the issues of why do it? Well, why are we doing it is because of the issues around enhanced bodybuilding practices. Yeah. And so, yes, it has some potential to lower IGF-1, lower testosterone level. And for a natural athlete, you're not going to face the issues of an enhanced bodybuilder with high amounts of insulin resistance or oxidative stress or inflammation is the same. Also, we would incur these issues at lower body fat levels too than say like someone that would be natural. So I don't use that on my natural competitors. I don't think it makes enough sense. I think the prophylactic measures that it might provide far outweigh what I see as even being the limited amount that it would impact, even if it did impact hypertrophy. And I just as an anecdotal, and it's very anecdotal, like I have not seen it impact progress. My guys are still adding stage weight on, but I am seeing improved markers of health. And so I think as a summation, I still lean in favor. However, it's very well like if you see that, there's not enough data to say, would this really impact some amount of gain in this population? Fair enough. Like we don't have the data that can really, really say that. And so that's a decision you would need to make for yourself. But I would say just from what I've seen in the field and practice that it doesn't seem to be limiting.
Yeah, and I would agree there. And I think just as a comment on the natural side, like the whole point of prophylactic is in response to like lower risk for something else that's involved, right? And so
Yeah.
the whole point of taking prophylactics for that, like it's there's not other things that are going to be risk. You're not taking risk adverse actions within natural bodybuilding that are the same as within like enhanced. So another kind of logical sequence is to like maybe this isn't something that needs to be like included, in my opinion. And if you're running into insulin sensitivity issues, it's probably due to the fact that it's time to change directions as a natural bodybuilder rather than or chronic inflammation issues. It's then like the presence of something else causing that, right?
Yeah. You think of it as like, hey, I'm running into issues. What do I take to keep going? It's like, take a step back. Like maybe what should you do now? Because you got to a point where you shouldn't be. So usually just adding more things in to extend that out isn't the best solution. But this is more so like something that we would have in place to prevent some of the issues occurring, or to a lesser degree.
Yep.
They may very well still go there. And then once they do go there, where we're seeing those maybe health markers are deteriorating, then we still pull back. It's not like, oh, take more metformin, take more insulin. It's like usually that gets pretty suboptimal really quickly doing so. And that's when I see guys it's just like trying to pull teeth to get progress. And you can just see guys look more swollen and watery, and inflammation's present. So it's just, this is a time to put a hard stop on pushing up. So you have to make consideration for how would be deploying this. Have you had any clients have diarrhea using metformin?
Yeah, diarrhea, GI upset. Absolutely.
Did you have any strategies you used around that, or what could they resolve? Or
one of the things I've seen is like, and not like a direct exchange here, but if it's deployed from the sense of like blood glucose control, like switching over to berberine a lot of times can be a solution. What I have found though is most people tolerate 500 milligrams fairly well, where I can leave it in as a prophylactic in that level. It's if it ever goes up into like the 1,500 milligrams. So I haven't had anybody run into issues at the 500 milligram mark. Most of the time it's been like an escalations of metformin. And so it's just pulling it back to 500 milligrams and controlling blood glucose via other measures.
Yeah, I think it's a low incidence. I think it's 5% of people that take metformin have continued GI issues. It can increase slightly upon first initializing it, because it might have some influence on the gut microbiome and increase of short chain fatty acids, which it might be a positive on the microbiome. But also what I mentioned earlier, it can prevent some carbohydrate absorption. So more carbohydrates, especially if they're like fermentable carbohydrates, could cause more gas, flatulence, and even diarrhea, and just pulling more water into the GI tract. And so usually it can resolve, but not with everyone. A lot of this can be an issue of taking it on an empty stomach. So what I usually suggest is definitely taking it like with the meal, or even right when you complete your meal, or at the time you start your meal. Timing wouldn't necessarily be quite as important with metformin, because it has a fairly long half-life in the body. So we're really looking to build up metformin in the tissue, rather than, don't think of it as I take this with X meal and it's going to be making me insulin sensitive for that meal, or partition that food. That's not how it works. It does build up in the system, and it's more so for decreasing glucose output. So it's not doing anything with like necessarily the carbohydrate that you're eating to make tissue more sensitive directly. By decreasing glucose output, tissue in turn gets more sensitive, because you're having lower insulin and glucose levels. So don't think of it as you're taking it with a meal and it's impacting that meal. But also I find taking it at nighttime helps, rather than having it more active during the time of day when you do have a lot of food in place. People have asked me about like extended versus immediate release. And for our purposes, it really doesn't matter. Like either version would be very acceptable. I the extended release might have a little less impact on GI because you're not having this huge wham of a dose at once, and just taking the evening. That way it might not be as impactful. You could split the dose as well. So if you find all 500 mgs at once is a lot, you could split that down or just even take less. Another thing you brought up, Luke, was berberine.
Yeah.
And there was some interesting studies on using metformin and berberine together that showed to be fairly effective than just a monotherapy of one. Mm-hmm. With berberine, so now this is a whole other question on itself. Like, is berberine better, or hey, take berberine without the side effects? And they do work through very, very similar mechanisms. Both work through AMPK, decreasing hepatic glucose output. The transporters for them are slightly different, and so are some of the pathways slightly, but they just end up for the same outcome of what they do. So they are very, very similar in mechanism of action. Some things about berberine is that it does have a pretty low bioavailability, but it doesn't seem to cause as much GI distress. So that could be an application for someone that just cannot tolerate metformin. Berberine, milligram for milligram, could be as effective for managing blood glucose. I just tend to see better outcomes with metformin personally. Other things around that conversation too, with berberine, there's not quite as much data on a lot of the other benefits that it does comparatively to metformin, since metformin is an FDA approved drug. We have a lot of research and data on it. So that's why I feel more comfortable with metformin, especially if you're able to get pharmaceutically grade, which you should, metformin versus a supplement, which the supplement industry is a mess. If you can actually how do you even know you're getting berberine? Which I've seen people that are not getting real berberine or underdose berberine. And so that's an issue within itself, for one, access. So it's like, well, if you can't even get metformin, yes, berberine would be a very, viable alternative around that. Why not just go to berberine? Well, for the other reasons that I mentioned, that's my consideration. But with that being said, if you couldn't tolerate 500 milligrams of metformin, you could do 250 metformin and 250 berberine. Berberine has a much shorter active life, so you might split those up. So you might do like metformin in the evening and then berberine like in the morning with your first meal. That could be a route to deploy it and implement it that way.
Yeah, I would tend to agree there too. It's just the state of the literature on metformin skews me very heavily towards it because I'm deploying it for the prophylactic reason as the primary, right? And so,
the other thing with it also might have some issues with metformin, like B12 deficiency.
Yeah.
Which I would say would be pretty rare for our population, because your B12, it's going to come a lot from your protein sources. Usually in most labs I see, it's high B12.
Yeah. Same.
An issue around this would be an issue for like pernicious anemia and the maturation of red blood cells, and seeing that like megablastic type of anemia from pernicious is rare for what I do come across sometimes in females, but usually that's a few different other variables. It might be around thyroid issues, or it could be around usually getting a folate. So the combo there, but not so much around metformin, just because B12, and even that, it's so high in all supplements, like almost your pre-workouts, your multivitamins, like all this stuff has usually B12 added to it. So not usually an issue that I see.
Me neither. Yeah, I don't run into the B12 deficiency at all. I was gonna say most of the time I see it high on lab work, kind of like you said. Yeah.
What else have you noticed just with implementing metformin or issues or
Net positives? I mean, honestly, man, like it's been one of those things that when we look across and we have other things that we're using as prophylactic, right? And so we're seeing the net benefit of like better stack design and prophylactic measures, and all of this contribute to overall health. I've actually started to see, and Josh is a pretty good example of this, just improvements in being able to manage the depths of off season a lot better. So he started with me around 224, 223. He's like 267 right now. And we are managing that a lot better than on average, like in the past it would be. And so like when we look at like health metrics on lab panels, we look at blood glucose markers, we look at blood pressures, we can take a conglomeration of all of these and just kind of see the overall health state of the individual. And it's just metformin being a contributing factor there, seeing the improvements in the overall health of the athlete as we take them into these extremes of these seasons, right? And that's kind of where the value is for me.
Yeah, I have a few clients that have some unique situations around metformin and
Okay.
having higher needs actually for it.
Okay.
I think for most of the clients using, on PEDs and 500 milligrams, no issues around this. But I have some that, like, if say you had a predisposition to diabetes, and of course you're higher body weight, pushing more food, and using growth hormone, it could kind of perturbate that, and you could bring about more glucose issues definitely very quickly. So, I mean, I have one client that does take, it'll range depending on what we're at in the season, but 1,000 to 1,500 milligrams of metformin. And that is what it's been taking just to keep their blood glucose normalized. And this is someone that for another client, they would have no issue at like this food level or anything having blood glucose control. But in this certain instance, since he has this predisposition, that's taken more metformin. However, I'd say this is like his most muscular state he's been. He's like, 265 and probably still around, 12% body fat, a large individual. And this was, coming up from a stage weight around 225. So it's putting on a significant amount of tissue, taking higher amounts of metformin. So, even though we have this, the the master study with in older natties, enhanced young, it doesn't seem to be even an issue. So that's what I would say. Like, moving that dosage up might be needed in individuals that might have that predisposition to actual diabetes. And that's usually asked, hey, do you have a family? Do you know anyone in your family that has diabetes or things like that? Then it's like, oh yeah, I do. It's like, okay, this might be a factor. The other one is PCOS.
Oh yeah, we didn't even bring this up.
Yeah, which PCOS can be multifactorial,
Yeah.
around what type of even PCOS it is, but typically you do see high blood glucose and high insulin levels, and metformin is a treatment in PCOS along with other things. But I have a female client that takes 1,000 milligrams of metformin to manage blood glucose, and that has not slown at all. Like she's like, we had a comparative pick, so like from over a year, and she's 7 pounds heavier and easily 2-3% body fat leaner. And so this is like, oh, would it inhibit muscle growth? Like, hell no. Like, it actually kept like our health markers in a better spot and still made a significant amount of progress for a female that's going to far less androgen levels than even a male. So I think it just further, like, in my mind, like, just shows like this isn't impeding progress. But those are some of the other kind of conditions where I've had metformin at higher dosage ranges for the needs of that individual client.
Yeah, I've had the PCOS up in the like 1,500 range before. So PCOS would definitely be one of the ones that I've seen. raise the need without a doubt. But I think that overall covers pretty much mostly we would do from a consideration of metformin inclusion. I think on a priorities list of prophylactics, it's pretty high up the list, in my opinion.
Yeah, it's if y'all had listened to our prophylactic on blood pressure, I think that is probably a number one.
Primary.
And metformin would be, I mean, not to rank these things, we put them both in place, but it would be right after there. A question I've had too is around, does your metformin take place? Because this came to mind. Does your metformin take place of insulin usage? And they just are completely different things, right? Metformin is enhancing the actions of insulin, so it makes you more sensitive to insulin's actions. Yep. As far as insulin, it's just a different conversation. It's like, what's your need for exogenous insulin in relation to your endogenous production? So if you say you were someone taking insulin, you might get the same effect out of a lower dose of insulin. That's like they could impact each other in that sense, but it doesn't do the same thing as insulin. Like, yes, they both can lower blood glucose, but it's through very, very different mechanisms of action. And it's just a different conversation. And the same thing goes with growth hormone. Like you can add these things together, and yeah, it's not an issue either.
And I would make the off comment of these are all independent of each other and not necessary within the usage of each other. As in, like, we don't have to use growth hormone, insulin, metformin all together. Like, it should be done based on that need.
Yeah, and I know people are going to get still tied up on, because it's such a debated thing because we just don't have the data on it on muscle building. But realize there's a lot of things that we take that could potentially increase AMPK, and you could make an argument that it's going to inhibit progress. Alpha lipoic acid, like that's in a lot of your GDAs. Oh, I'll take a GDA. I won't take metformin. Like a lot of the mechanism of action of all those ingredients are very similar in that they do work through AMPK. Hell, you could make an argument for caffeine. It has a similar mechanism in that sense too. Or you could look at, oh man, taking antioxidants prior to training inhibits some hypertrophy adaptations. It's like, oh shit, well, you know what? Let's stop eating fruits and vegetables, right? It's like for how strong the drive of androgens, growth hormone are to promote progress, like these things are not going to slow down your progress. If anything, it's just going to help with health. I think it's just very, very overstated the impact of these things, and we shouldn't just look at little mechanisms. That we should look at, what's the big picture here and how it's working in an entire system. And it does have to get a little bit anecdotal in the trench of what we're seeing, because you're not going to have research on enhanced competitors, high food, or in preps, taking drugs. It's just, you're just not going to have it. So you have to rely on people that are just coaching a lot of individuals and seeing what they're putting into practice. And of course, realize what are the variables that might be in play and how it might be. But again, you have guys still reaching high levels in competitiveness. So that is the wrap up, I guess, for metformin. Lots of things to consider. And if it's something that you see would be beneficial, within your progress, I think it's something to investigate more. We have our thoughts on it, and it's ever changing. So, as more data comes up, we're happy to update you guys.
Yep. 100%.
But any comments, questions, leave them, share, like, subscribe, wherever you're at. Appreciate you guys following along and liking the content. All right. Talk to you all next time. Later.